Good afternoon, Kenny. Really nice to meet with you. For those who are listening to this, I'm meeting with Kenny Gibson, National Head of Safeguarding for the NHS. I'm Sue Hill. I'm the Project Manager for Resilience-Based Clinical Supervision at the Foundation of Nursing Studies with their social care programme. And Kenny and I are going to talk about all things safeguarding this afternoon. So hopefully you'll find this really interesting. So, Kenny, can I start by asking you, what is the definition of statutory safeguarding?
Thank you, Sue, for the invite to participate with our allies in the Foundation of Nursing Studies. Before I go into the statutory definition of safeguarding, I think it is important just to all things safeguarding, particularly for your fabulous programmes of work, is to remind us all about welfare and self-care, because in every arena of restoration and supervision, things are disclosed and things are shared. So yes, colleagues, as Sue says, we're here to have a conversation about safeguarding, bit of welfare, bit of self-care. The definition of statutory safeguarding is ever changing, actually. I came in 6 years ago as the National Head of Safeguarding and with a few programmes. But these are an ever-increasing number of moments in any one of our lives, whether we're a patient or a practitioner, that have a lawful, legal and policy basis to them. We're not going to remind everyone and they're not going to recall everything we talk about. So we will plant through the Foundation of Nursing Studies the NHS Safeguarding app. And that will tell them the changing statutory safeguarding programmes. But in summary, they are child protection, they are female genital mutilation, they are prevent the radicalisation programme. It also includes modern slavery and human trafficking, all forms of domestic abuse, including domestic homicide reviews, and very recently, serious violence duty. So if registrants or professionals or carers find themselves in this moment of statutory safeguarding, they need to know how to escalate. They need to know how to find resolution in them. But again, they'll be in this NHS Safeguarding app, and we'll make sure that colleagues have access to that.
Thank you, Kenny. So what do you think are the current issues in social care for statutory safeguarding?
We're very lucky that we've been listening to social care colleagues for many years, because the people that need safeguarding in the NHS and healthcare often start their journey within social care settings, whether that's care home or cared for at home, etc. We have an epidemic of, and we need to bear witness to the fact of, two important phenomenons that we've come to know rather too well over the last few years. One of them is domestic abuse. And this is not only domestic abuse about the people we care for, Sue, so our patients, our clients, our residents, our caseload. It's actually our own. Carers and practitioners of all types have had the courage to share their own domestic abuse. And so it's really important to us to recognise this within a social care setting. It's not only about residents, it can be about ourselves, and it most certainly will be about colleagues and those we work alongside. The other main area of issues at the moment in social care is child sexual abuse and exploitation. And whilst social care doesn't always care for children, what we're looking at here is the lifelong impact of being sexually abused as a child into adulthood. The shadow of being abused as a child, particularly sexually or exploited online, which is a new phenomenon, can last a lifetime. And I certainly had the humbling position of being disclosed to by 80-year-olds who have found the courage to talk to me about their abuse as a 4-year-old, their exploitation by family and people in their communities as a teenager. So it never leaves us. We call it non-recent, but the impact on adults is really quite phenomenally important for us to grasp in social care. There are parties in social care that do care for children. And so therefore they and we must be cognizant of child sexual abuse, both within family environments or community-based, or as I say, the absolute growth and explosion of child sexual exploitation online. So if you are caring in a social care environment for children, then it's very acute at the moment, but let's also bear witness to adults and the impact of non-recent child sexual abuse as well.
Thank you, Kenny. How is welfare safeguarding different from statutory safeguarding?
Statutory safeguarding has legislation, policy, mandate and competences with the intercollegiate document that are well written and drafted to remind us what our obligations are as paid carers. Welfare safeguarding, we have framed this in the pre-statutory phase. So many of us, we shouldn't wait for domestic abusive relationships to start. We mustn't wait for a domestic homicide to occur. We mustn't wait for female genital mutilation to be done onto female children. We must be cognizant of welfare. And they can often be, for instance, the first sign of neglect, the first sign of self-harm, the first indications of pinches and punches. So they don't meet the threshold of statutory, but the signs and symptoms, the behavioural change, loneliness, isolation, all of those things that we're cognizant of, that adults being cared for in a social environment or a domestic environment or a social care environment you can begin picking up isolation, loneliness, a bit of self-neglect long before the willful neglect happens. And those welfare moments, the signs, the symptoms, the early indicators, if you will, they are there so that we together can prevent harm, both to children and vulnerable adults. So welfare safeguarding is often those early stages, first indicators that something isn't quite right. And we've got to use our preventative hat to stop the statutory incidents from occurring.
So really using the intuition we have when we meet people that things aren't quite right.
I would agree. I think that intuition is everything. Whether it's a bruise you see on someone's elbow or someone removing themselves from you as you go to support them, etc. Those neurolinguistics, the types of words they are using, etc. Really important to go with your intuition and discuss your intuition, particularly if you work regularly in social care with someone at home or as part of your visit to a household or family. Yes.
Here at the Foundation of Nursing Studies, we're delivering the programme Resilience-Based Clinical Supervision, which really encourages people to talk about their emotions. How do we support participants with welfare safeguarding issues?
Yeah. Well, first of all, your programme is fabulous. I think there is huge benefits from coming together to learn about restorative supervision. So thank you for continuing to expand on it and deliver it. It's a phenomenal program. But you're right, the core of that is supporting each other to share, to talk through their sort of their journey, whether that's their journey with patients or citizens or residents or their own journey through their own life course experiences. What I find helps support participants in clinical supervision or restorative supervision about welfare is to listen. The power of actively listen. And when I say actively listen, I mean the power of their words, the person you're sitting with, to deeply listen to the words that they have, because some of the words will be about being a victim, a very recent victim. Other words will be what we call survivorship words. It might have happened a while ago and they're looking at survivorship. Some of them might actually be resolved of their trauma. So the power in their words, the power of their words is everything. And I think the restorative model lends itself very well to playing back those words. Not totally repeating in parrot fashion, but to build them in, to demonstrate that we've heard and we've borne witness to their words. I think the other thing that helps welfare safeguarding is the supervisor will not be able to rescue anyone from that group, nor should they ever set up themselves to be the rescuer. Sometimes individuals will disclose a welfare safeguarding issue in the midst of what we would call a Cartman's drama triangle. They may be being persecuted or they may be being looked at as a rescuer themselves. And it is really critical that group supervisors and clinical supervision actually use signposting. So they need to understand that when a disclosure happens, the facilitator, the supervisor, is not seen as the rescuer. They are seen to create an independence of recovery by signposting. So what did the person do previously whilst they were in that type of situation? So it's really important to build on the words and to create an independence in recovery, and remember signposting to peer advocacy services. Do not create a codependency, would be my number one tip in welfare safeguarding disclosures.
I think it's really, really important. And especially as nurses, we often want to fix people, don't we? Make them better.
Absolutely. Yes.
So the signposting is really, really important.
Yes. Absolutely. Yeah.
One of the other things I've heard about is this concept of hypervigilance in a safeguarding incident. Can you explain that a little bit more?
Yes. I think many of the people coming on your course are on the course because they know they've been in that moment of drama or hypervigilance themselves. For me, those moments of disclosure are not dissimilar to someone disclosing post-traumatic stress disorder or PTSD. Because as someone discloses, they may have taken weeks to summon up the courage. They may have taken months, or as in the case of the person I was relating to earlier, they may have taken decades. But in disclosing that moment, the facilitator has to be ready to listen. Listen without judgment as well, because the disclosure will come from memories. Those memories will raise upset. There will be visceral sense. There will be group think about those visceral senses. There will be feelings. There will be emotions, and those are really important to deal with. And some of those feelings are very, very difficult to hear, particularly if your culture doesn't allow you to hear the words. And this is where welfare alerts are really important, because sometimes even talking about types of domestic abuse can be very challenging for some people with social norms, let alone using the words child sexual abuse at scale. So that sort of moment of disclosure, the courage of that victim survivor can be matched with negative feelings from those in the space. It might be horror, anger, guilt, shame, or re-triggering. And that's where the hypervigilance needs to happen. We need to be cognizant that the disclosure, that moment of courage, can actually have other types of visceral feelings in those people impacted by the disclosure. And those have to be spoken through or offline, taken, and a more suitable debriefing process happens. If they stay in the group on the shoulders of individuals, that's where hypervigilance comes in. So it's about psychological safety. People will disclose moments occasionally, but how does that make others feel? And what are they going to do with those feelings to divest themselves before they go on to their next intervention or before they begin going back to their work? So it's all about that psychologically safe process. What's been said has been said. It has a visceral impact. What are you going to do to move on and be able to process that, divest it, and move on with the rest of your day, the rest of your week, and in some cases, the rest of their career and life?
Thank you, Kenny. I was going to ask how social care colleagues might support this, but I think perhaps you've answered that.
Yes, I think it is listen, don't judge, or even the thing I often find myself torn, particularly if social colleagues have a practitioner curiosity, is don't seek validation either. You know, just let them say without judging or validating. But it's about knowing how to signpost and how just to move things on, and be psychologically safe, which is at the foundation of your program anyway. So,
So true.
ideally suited skill there.
Thank you. So my last question, and again, I think we may have done some of this already, but do you have any key messages for our facilitators to draw out both the unsaid and the undisclosed safeguarding issues?
Yes. Download the Agile Safeguarding Guide so that you know what these programs are. I think don't push the unsaid and the undisclosed. It may not be that group and it may not be you, but maybe reach out afterwards if an unsaid, undisclosed is happening to the individual. So it may not be the group. But as I say, listen to the power of the words. Use a bit of confidential inquiry afterwards with them. You know, how safe do you feel at home is an often good question to ask that we've learned. How safe do you feel online if it's about online abuse? But it's signpost, and don't fall into this clinician wanting to fix the journey into that safeguarding moment. You can't. But I think one of the key messages is to bring hope. I think bring hope. There is a host of organizations, peer advocacy, culturally sensitive organizations that can support someone's recovery without you rescuing. That would be my key messages.
Kenny, thank you so much. That's been
You're
really
very
helpful.
welcome. And
Thank you.
thanks for your ongoing support in the programme.
Thank you.